covering an awful lot during today's webinar. First, I'll let you know who I am and my background and what some of my qualifications are for this particular topic. I'm licensed in Florida as a mental health counselor and a marriage and family therapist, and I work in a private practice called Integrity Counseling, where I do clinical and forensic evaluations and individual and couples and family psychotherapy. I also teach as an adjunct at the University of South Florida in the College of Behavioral and Community Sciences. And as I mentioned before, I'm the executive director for the National Board of Forensic Evaluators. And I'm also the Southern Regional Director for the American Mental Health Counselors Association. I'm right now working on my dissertation to finish up my doctorate in counselor education and supervision. As far as substance abuse evaluation goes, I have 18 years of experience with substance abuse evaluation, and I am certified here in Florida as a master's level addictions professional. I also have my international certification as an alcohol and drug counselor. I'm certified by NADAC, the Association for Addiction Professionals, as a master addiction counselor. And then also an SAP, or substance abuse professional, meaning that I'm qualified to conduct substance abuse evaluations for the U.S. Department of Transportation. And then I also am recognized as a diplomate and clinical mental health specialist in substance abuse and co-occurring disorders with the American Mental Health Counselors Association. So we're going to have different handouts that will be available for you today. And I provided a link that you'll see right here on the screen, app.box.com/v/substance abuse evaluation. That is a link that you would go to access various handouts that we'll be providing. And again, if you fill out the evaluation form, you will get this web address in a follow-up email in case you miss it right now. What's going to be in that folder will be two different versions of the slides today. One has space for writing notes, but because that makes the slides kind of small and blurry sometimes, we also have a very high quality PDF version of all of the slides without any space for writing notes. There's a DSM-5 substance use disorder checklist that might help you with your assessments that we'll talk about later, as well as a matrix that includes information from the ASAM treatment guidelines. And there's going to be a link to the video recording of today's webinar. But in addition, this morning I parked some resources in there about urinalysis drug testing detection periods. And also I shared my forensic evaluation referral form that I like to send to attorneys when they are referring clients for forensic evaluations. This is the website that you will find the recording for today's webinar. But again, you'll get that in a follow-up email as well. All right, I'm just going to check because I do see that the questions box is marked here, but then I went into it and I don't actually see any questions posted. So Norm, if you're there, could you do me a favor, because I wonder if this is the same glitch we were running into last time, and kind of peruse the questions box for me, and then when I pause at different points to ask for questions, could you let me know if anybody is asking anything? All right, so the objectives, what are we going to talk about today? We're going to identify the diagnostic criteria for substance use disorders, and then we're actually going to try to apply that criteria in a case scenario that we'll be reviewing today if the technology lets us. We run into problems when we try to view videos sometimes on live broadcasts. We'll also learn about several questions that can be asked to determine if a client meets the diagnostic criteria for one or more substance use disorders. We will identify some tests that you can administer to identify subtle attributes of substance use disorders that have built-in validity scales to detect defensiveness, denial, and inconsistencies. You'll learn how to use collateral sources, those are sources other than the client, for additional information, and how to identify what to look for when you're reviewing those sources to help determine or help supplement other information you gather to determine diagnoses and treatment needs. And then we'll also be exploring briefly the American Society of Addiction Medicine, or ASAM, treatment criteria, and we'll learn how to apply the criteria to the data obtained from the biopsychosocial assessment to determine a client's specific treatment needs. Now, this evaluation is going to be focusing on forensic evaluation, but if you are not doing forensic evaluations in your practice and you're more interested in clinical or therapeutic evaluations, we expect that a lot of the information we'll be sharing today will be helpful as well. So just a couple terms that we can get out of the way so that you understand what we're talking about as we move further into our content. The first is the term addiction, which means so many different things to so many different people. A definition I like to use is that it is a phenomenon that occurs when an individual repeatedly engages in a maladaptive pattern of behavior that activates reward circuitry in the brain despite recurrent and clinically significant problems related to that behavior. Now, although we're really going to be focusing on substance use disorders and on chemical dependencies or addictions during today's webinar, I want to note that there's certainly other addictions. There are sexual addictions, and compulsive gambling has been thought of as being an addictive disorder. So we won't be talking about those today. The definition offered, or an essential feature offered by the APA and the DSM-5 for substance use disorders, is that disorder is a cluster of cognitive, behavioral, and physiological symptoms, indicating that the individual continues using the substance despite significant substance-related problems, which you can see is pretty close to my definition for addiction, only specifically applied to substances. All right, so we're going to launch our first polling question here. Let me back out of the presentation real quick so that I can launch that polling question. Oh, let's try this again. All right. First polling question should be on your screen right now. And I just want to kind of tap into the audience here and see who we have today. I'd like for you to identify all of the following that describes your professional identity, so you can select more than one option. Your options are clinical mental health counselor, clinical social worker, marriage and family therapist, clinical or counseling psychologist, and then finally we have a category for other. So I will give you a moment to chime in and we'll see who we have out there today. So we'll close this polling question out and share our results. 84% of you said that you identify as being a clinical mental health counselor. 6% of you said clinical social worker, 10% marriage and family therapist, 13% clinical or counseling psychologist, and then finally 19% other. I'm also curious about which of the learning objectives that I shared with you a moment ago that you are most interested in hearing about today. What really is drawing you into today's webinar? Your options are identify diagnostic criteria for substance use disorders, learn questions that can be asked for diagnosis, identify tests to use for evaluations, learn about collateral sources of information, or finally, explore the ASAM treatment criteria for assessment. Right, most of you have responded, so I'll close this polling question out, and then we will launch our results. The most popular objective, 42% of you said that you are most interested in identifying tests to use for substance abuse evaluations. 26% of you said that you're interested in learning questions that can be asked for diagnosis and for exploring the ASAM criteria. And 6% talked about collateral sources. None of you were most interested in the diagnostic criteria for substance use disorders. All right, maybe we'll skip the diagnostic exercise. We'll see how time goes here. All right, so the last polling question that I will launch for right now is what percentage of adults in the US meet criteria for alcohol use disorder at some point in their lives? So your options are 7%, 15%, 23%, 25%, or 29%. You are estimating the percentage, the lifetime prevalence, the percentage of adults in the US who will meet criteria for an alcohol use disorder at some point in their lives. It looks like most of you have responded here, so let me go ahead and close this polling question out and we'll share our results. The most popular answer with 39% was 25%, but second was 35% of you saying 29% of adults will meet the criteria. And then 13% of you said 15%, 10% said 23%, and then finally 3% of you said 7% of the population. Let's review the answer for that last question. So one point I want to make is regardless of whether or not you consider substance abuse or substance use disorders to be an area of specialization for you, you are working with these disorders. All of us are working with these disorders because they're so common, they're so prevalent. the lifetime prevalence for alcohol use disorder alone is close to 30%. Roughly 1 out of every 3 adult Americans will meet the diagnostic criteria for an alcohol use disorder at some point in their lives. What other disorder can you think of that 30% of the population will meet the criteria for at some point in their lives? This is a very common and very prevalent disorder. Only about 20% of those who meet that criteria will ever be treated for alcohol use disorder. So it is a very undertreated population. Roughly 10% of the adult population will at some point in their lives be diagnosed with some other substance use disorder, in other words, some disorder besides alcohol use disorder, of whom roughly 25% will receive treatment. And we also have information on our 12-month prevalence here. So even if you looked at the past 12 months, roughly 14% of the adult American population has met the diagnostic criteria for an alcohol use disorder, and roughly 4% in the past 12 months have met the criteria for another substance use disorder. So again, a very, very common group of disorders that we're talking about when we talk about substance use disorders. For those of us who do forensic work, and also for those who do clinical or therapeutic work, there's quite a connection between drugs and crime for several reasons. Drug users report greater involvement in crime. They're more likely than non-users to have criminal records. People with criminal records are much more likely than others without records to report being drug users, and crime rates increase proportionately with increases in drug use. Now, that's not just because of the fact that there are literally charges out there that are clearly substance related, like DUIs or possession charges or trafficking charges, but you also will want to consider here that, I spent 4 years doing ride-alongs with police officers, for example. And when we would respond to domestic calls, oftentimes somebody would be under the influence of a substance, most commonly alcohol. Similarly, many of the burglaries that we dealt with involved individuals who were being motivated by their drug use, or for that matter, prostitution charges. Any number of charges seem to be related to drug use. Battery charges in bars, disorderly conduct and disrupting the peace, criminal mischief, an awful lot of crime. The Florida Department of Law Enforcement, for example, once estimated that roughly 80% of the crime in the state of Florida was in some way substance related. So there's quite a strong connection, and that's part of why we deal so much with this in the forensic arena. So let's launch another polling question here. For this polling question, we're going to be interested in whether or not court-ordered substance abuse treatment is more or less or equally effective as voluntary treatment. So here, think about your clients who self-refer versus your clients who are referred through some kind of legal entity for treatment under some kind of coercion or pressure from the criminal justice system. So your options are, you can say that court-ordered substance abuse treatment is more effective compared to voluntary treatment, less effective, or equally effective. And we'll give you a moment to chime in on what you think the answer to this question is. All right, so 89% of you have chimed in. We'll go ahead and close this polling question out and launch our results. 64% of you said, we think it's less effective than voluntary treatment. 33% said equally effective, and 3% said more effective. All right, well, let's see what we have on our slide here. So actually, the evidence seems to suggest that mandated treatment is equally effective as voluntary treatment, which surprises the majority of clinicians. Most of us, we assume and we commonly say, well, they really have to be ready and they really need to want it or need it. They have to hit their rock bottom. And if someone else pressures them or coerces them into treatment, then they're unlikely to be benefiting. But the reality is the data doesn't substantiate that, at least according to the National Institutes of Drug Abuse and the National Institute on Alcoholism and Alcohol Abuse, as well as many other authorities in the substance abuse treatment field. Now, we see this all the time. We do a lot of DUI mandated treatment here, for example. Clients usually come in pretty defensive and resistant and not exactly very happy about being here because they didn't wake up one day and decide that, have an epiphany and say, you know what, I'm really experiencing some problems connected to my drinking or drug use, and I ought to go talk to somebody. They came because they're being required to, either as a term of probation or by a court order, or because they want to get their driver's license back or maintain a driver's license if they still have it. So they're not usually very happy about being here, but it usually only takes a week or two before their attitude really changes about being in treatment. We tend to see a shift as they get into the treatment and they start participating. We tend to see that they start opening up to what we have to offer. They see that the staff here are genuine and care very much about them. They feel supported and understood by their peers and by the time they reach the end of their treatment and their evaluation forms, they're giving us really high ratings, even though these are anonymous evaluations. And they're saying things like, man, I wouldn't have come if I wasn't required to, but I'm so glad I did because it was very helpful. So that's something to keep in mind, is that it doesn't seem to matter ultimately whether they were pressured by the legal system or not in terms of outcomes down the road, specifically remission and recidivism rates. One of the challenges with substance abuse evaluations is that denial is embedded in the disorder itself. In other words, in order to develop an addictive disorder, you really have to have a pretty complex psychological defense system that has evolved over time, such that you can maybe even look forward to, certainly rationalize and justify the very behavior that is creating most of your problems, or at least many of your problems. That requires denial as a defense. That doesn't mean that the person maintains that denial or that the denial doesn't shift or change over time, but at some point for the disorder to develop, there really has to be some type of denial. And because of that, you're going to be working with or evaluating clients who are experiencing denial, and that is the norm and not the exception to the norm. But there are other threats to validity. Positive impression management is one. This is a phrase that we use to describe when somebody is trying to make the clinical picture look, or they're trying to make themselves look better than the actual clinical picture would warrant. So these are individuals who are trying to send you the message, I'm fine, everything is great, there's no problem here. We may see this, for example, in the forensic arena when somebody's been referred for a substance abuse evaluation in connection to a child custody case, because they really want custody, or they want to have equal or some degree of parental rights. They want to convince you that they don't have a problem with substances, even if they do have a problem with substances. Or similarly, if somebody were seeing me for a DOT violation, they want to be returned to work as quickly as possible, so they often will want to minimize the problem so that they can get back to work quickly and not be required to participate in a more lengthy term of treatment. But sometimes you'll actually see the opposite in the forensic arena. You may see negative impression management. Great example is, for 4 years, I worked in a Department of Corrections program for substance abuse treatment. And what we found is that sometimes there would be drug dealers in jail who would learn from other inmates or from their attorneys that if somebody has a problem with substances, then the judge may sentence them to residential substance abuse treatment instead of a prison sentence. And suddenly they will start talking about having a problem with crack cocaine, maybe, for example, when they've never used crack cocaine. So then they'd come into the residential program and they tell us, oh yeah, I lied to get here, so I don't really need to do any of this stuff anyway. It doesn't apply to me. That would be an example of negative impression management. They're trying to make themselves look worse than the actual clinical picture would warrant, because there is some type of external reinforcer for doing so. You could also think of that as being malingering. A third threat to validity is neurocognitive impairment. Some of our clients are not very good historians. Some have different cognitive impairments that will make it harder for them to draw connections or remember information accurately and report it accurately to you as the evaluator. Additionally, some clients have a lack of insight. In fact, that's very common when it comes to addictive disorders, as I talked about before. So it may not be that they're necessarily trying to lie to you intentionally or to be dishonest, but they just don't draw the connections between the consequences of their use and the use itself. They don't draw that causal connection the way that some outside observers would. And then maybe because of denial or defensiveness, they'll have a hard time accepting that connection if somebody else points it out. So Norm, I noticed that there are some questions here you told me, so maybe we could pause here for just a moment and address some of those.
First question, how do I get slides?
All right, so as I pointed out earlier, there are a few ways you can get slides. One of them is you can click on the triangle next to handouts on your GoToWebinar control panel, and you can access the slides that way. Alternatively, there's a link that we shared at the beginning of the PowerPoint that can allow you to access slides. And if you complete the evaluation form today at the end of the webinar, you will receive an email within a couple of days here that include all of the slides as well.
Marissa Jordan asked, do you know if the crime connection is primarily due to drug use or partially determined by manpower of police officers?
I do not understand the question.
I don't either.
So maybe she'd be willing to be unmuted and she could ask her question directly to us or explain it a little bit. Would you like to try unmuting her, Norm? Or I could try on my end. Let me see if I can.
I'm looking for her.
Sure thing. Now that was Marissa. So,
I got it.
Oh, you got it? Great.
Yep.
Hello.
Hi, Marissa.
So my question is because in my capstone of criminal justice, we talked about how there's a correlation between how good the crime rate looks and whether or not there are enough police officers, because of course the more arresting officers, then the more crime is going to be there. So knowing that the manpower differential can change, how does that impact whether or not substances still have an effect on increased crime rate?
I would certainly agree that the number of police officers available in any area will probably lead to increased arrests, whether those are substance-related arrests or any other type of arrest. Standard property offenses, for example, or it's same thing with speed infractions, traffic infractions. If you have a high concentration of police officers on the interstate, you're gonna have more traffic tickets. So yeah, I'd certainly say that that has an effect. I wouldn't say that's the primary problem in terms of arrest, but that would certainly have an effect.
Thanks.
Sure thing.
We have three more questions. Are there some drugs that have a higher rate of correlation with crime than others? Pamela Paul asked that.
All right, that is a good question, Pamela. I don't know the answer in terms of ratio, but what I can tell you from what I've read and in my personal experience, I see more alcohol-related legal problems than any other substance. But keep in mind that that's also because alcohol is the most commonly used addictive substance. So we're going to see more of it in treatment, and we're going to see more legal problems connected to it as well. But I don't have exact numbers for you, unfortunately.
Tanisha Stewart asked, can you expand on the term malingering?
Yes, malingering is the intentional feigning of disorders or symptoms for some kind of secondary gain, an external gain, such as for money or maybe to get out of trouble. So when I described earlier, for example, if there were an inmate who exaggerated his problem with substances so that he could avoid prison and instead go to a residential treatment program that he thinks will be more comfortable, that would be malingering because he's faking symptoms of a substance use disorder for an external gain, in this case, more comfort or a shorter deprivation of freedom or something along those lines.
And the last question is, can you place yourself on the top instead of the center because I can't see the full slide?
So this sounds like somebody is talking about their webcam view. So you all have control over your own webcam views. I cannot control that at all, and it will look different on each of your devices or systems. What I can tell you is that when you see me on a webcam, there are ways to drag and slide so that the webcam view becomes smaller or larger. And there's even a way to take off the webcam view. I can't remember exactly how to do that off the top of my head because it looks different for me, but you should be able to control that on your end. Be the short answer.
And that's the end of the questions.
Okay, great. Well, then we will kick right back into our slides here. Moving beyond threats to validity. I love Ackerman. We'll talk some more about him later on. But another good reason for us to be doing a lot of training on substance abuse evaluations is, I think, pretty well characterized by this quote from Ackerman's text, The Essentials of Forensic Psychological Assessment. And by the way, every time that you see a reference, you'll see that I've hyperlinked a way to access that material. If it's free, then you'll be able to get the full access by clicking on the link. But if it's a book, like in this case, then it's going to take you maybe to Amazon or something to show you the book and what it looks like. And if you wanted to buy it, you always could. I don't have any kickbacks or connections to any of these books that are being sold. But Ackerman said relatively few psychologists have adequate training and knowledge in the area of substance abuse evaluation or treatment. There are even fewer psychologists who believe that it is within their area of expertise to evaluate, testify, consult, or provide other substance abuse information to the criminal or civil courts. So I can tell you from experience, I certainly believe that to be the case. I have many friends and colleagues who are psychologists who work in the forensic arena, and they do a lot of forensic evaluations, but they don't have expertise in substance abuse. Consequently, when I worked for the state, for example, for quite a period of time, we would get psychological evaluations back that did a great job of evaluating for other co-occurring mental disorders or for intellectual disorders, sometimes learning disabilities and so on, but the evaluations were extremely weak on substance abuse, and that created a lot of problems for us. So conversely, most of you, it sounds like, are counselors or social workers. I would argue that you're more likely to have expertise in substance abuse than the average psychologist, because most substance abuse treatment programs are staffed by counselors and social workers rather than by psychologists. So the probability that you've got a strong background and training in that area that you can bring into this forensic evaluation arena might be greater, and there certainly is a shortage of experts. Why is this topic so important to me? Because I think clients deserve a thorough and objective evaluation, because big decisions are going to be being made that will impact their life and their family lives. And that's not to be taken lightly. And we need to make sure that we have good quality information to make those decisions with. But conversely, other stakeholders include the community. They include victims, they include the legal system, society itself. Everyone deserves a thorough and objective evaluation to be part of the process. Also, clients deserve to be treated with dignity and respect. And in my experience, in some treatment arenas and the mandated populations, I don't think they get that. And then third, I want the judicial system to take our profession seriously. Every time that one of us submits a very poor quality evaluation to the courts, I believe that that has an effect on the judicial system's faith in what we do. So I would love to see more quality evaluations, and at MBFE, we're here to help you to train and become better and better with your evaluations. That's why we do these webinars. Now remember, even though I just talked about some of those motivations, we as forensic evaluators are not client advocates. We are advocates for the truth. So I will refer to the American Mental Health Counselors Association Code of Ethics periodically throughout the webinar, even though there are many other codes that say very similar things. We objectively offer our findings without bias, personal opinion, or investment in the ultimate outcome. That is very difficult for many people who have been therapists or clinicians whose jobs are to help clients accomplish their goals or to advocate for clients. This is a very different role that you have as a forensic evaluator, to be very objective. Another is that we do not ever want to be perceived as a hired gun. That means that if just because the defense attorney hires you to do an evaluation doesn't mean that your findings will be swayed towards the defense. Your findings should be the same regardless of who hired you or paid for the evaluation, if you're being truly objective, if that's even possible to be fully objective. We do not act as an advocate for the legal system, the perpetrators, nor for the victims. We are an advocate for the truth as best as we can construct it with the data available to us. And again, very different than what a lot of clinicians are accustomed to. Also from our code of ethics, mental health counselors base their diagnoses and other assessment summaries on multiple sources of data whenever possible. You will see that highlighted throughout the webinar. We need multiple sources of data and not just one. Sadly, in the substance abuse evaluation arena, what I see a lot of times is that there are programs and evaluators who simply do a glorified biopsychosocial assessment based entirely on the client's self-report. that is a poor evaluation, and it does not draw on multiple sources of data. And what I see is a lot of places providing these evaluations and submitting them to the courts, charging as little as $75 for such an evaluation, where they spent very little time with the person, just ask them some questions on a psychosocial form and then send that in. And that's exactly the kind of practice that I'm trying to teach people to move away from. Mental health counselors are careful not to draw conclusions unless empirical evidence is present. And a client self-report is not enough to say that we have obtained empirical evidence. So on that note, what are the components of a quality evaluation? Again, we'll reference Ackerman because he is one of the most world-renowned figures on forensic evaluation. He proposes that there are 4 primary sources of information, including the clinical interview. I do think that is the most important data source, but certainly never sufficient by itself. Second, a review of records. This can include treatment records, both psychiatric or mental health related and substance abuse related, but also biomedical records, like records from a physician, for example, or a hospital. Any previous evaluations that have been conducted should be reviewed by the evaluator. Arrest records and public records should be reviewed. And court records and hearing transcripts sometimes can also be a helpful record. Third, we have collateral information, which basically consists of interviews or other information obtained from people besides the client about the client, such as spouses or partners, family members, employers, and 12-step sponsors for clients who have one. And then finally, objective test data. These are normed and substance-related psychological tests, preferably that have scales built in for trying to assess validity. In other words, can we trust what the client is telling us? And then also drug testing, I believe, is an integral component for substance abuse evaluations. So let's break down these 4 sources of information next. Let's start with the clinical interview. I would say that a clinical interview would start with your informed consent process, then move on to discussing the circumstances related to the referral. Then there's a diagnostic interview where you're trying to determine whether one or more substance use disorders are present. And then there's a biopsychosocial assessment where you are assessing all multiple domains of the client's life to try and determine what kind of treatment needs they may have. So there's a lot of information we're collecting with a clinical interview. And to set the stage, I think it's important to have a clean and comfortable environment whenever that's possible. So in my own practice, what we'll normally see is very comfortable seating, warm earthy colors, dim lamp lighting, the kinds of things that say you're coming home instead of you're coming to a correctional facility or something along those lines. We greet our clients warmly, but also, I should have said professionally is what I meant to say on this slide. Greet your clients warmly, but also stay professional in your interactions with them. And the third point is, quite honestly, I always offer my clients a beverage. Not that kind of beverage, not an alcoholic beverage, but a beverage meaning tea, coffee, water, something along those lines, because I think it's hospitable and appropriate, but also because we're going to be doing a urinalysis drug test as part of the evaluation. And so sometimes having some water on hand will help the client to be able to urinate when we get to that part of the evaluation. So this is how I do things. I'm not pulling this from some kind of manual. Sadly, I've never found a good text that really goes into great detail about how to do substance abuse evaluations. I've seen chapters within a textbook that hit on it, but if anybody ever finds it just a good, encompassing, thorough manual or a book on just conducting substance abuse evaluations, I would love to hear from you about it. So coming back to the code of ethics, the client in a forensic evaluation will be informed about the limits of confidentiality, the role of the mental health counselor, and the purpose of the assessment and potential for unfavorable findings. If you're not discussing this with your client, then you really haven't obtained informed consent. I'll also tell you one reason we like to reference the AMCA Code of Ethics is that they have a very thorough section on forensic activities compared to many other associations' codes. And actually, you've heard me refer to Norm a few times, who's helping to moderate this webinar. Dr. Norman Hoffman is the founder and president of MBFE, and he helped consult with the American Mental Health Counselors Association when they revised their Code of Ethics in 2015, especially on the forensic section. So we have a lovely letter from Joel Miller, the executive director of AMCA, thanking MBFE for its work in contributing to the Code of Ethics and to the body of professional literature in this area of specialization. So I give you an example over many slides here of what an informed consent discussion might look like for me when I'm meeting with a client. When I meet with a client, they've already reviewed information on confidentiality and informed consent in writing, and they've already signed off on that information unless they had questions. But that I don't stop there. That's not enough. When they come in and I see them in person, I'm going to rediscuss all of this with them, review it with them, and make sure that they understand it before I go forward with the evaluation. So they have all of this in mind as they meet with me. That to me is the ethical thing to do. And I think it also helps to protect me if I were in court, for example, and people are asking about my informed consent process. So this means I'm discussing with them the possible exceptions to confidentiality, such as report of abuse or neglect for a vulnerable individual, imminent or serious harm to self or other identifiable people, a medical emergency, a signed court order from a judge, and a release of information that the client has signed are all scenarios where I can be sharing confidential information. I ask them if they understand what I've described and if they have any questions. And with that information in mind, if they'd like to go forward with the evaluation, they pretty much always say yes. Then I tell them about the evaluation itself, how it works, the kinds of things we'll be talking about, the procedures that I'll be using. I explain to them the protocol for the urinalysis drug sample that I'll be collecting. The way we do it here is we collect the urine specimen on site. It is, however, unobserved, and that is a weakness, you could say, in the way that we do things, but it's also unannounced. So we don't tell them that there's a urinalysis drug test as a part of the evaluation until they are here for the evaluation. And then they have a choice to participate or not participate. We don't give them advance notice because if we did, the probability increases that they will try to adulterate the specimen or that they will try to time the evaluation so that something has worked itself out of their system, and we want to reduce that likelihood. Second, we have measures like we test the temperature of the specimen to see if it's below body temperature and therefore has been sitting around for a while, like they smuggled it in or something. We have them turn their pockets inside out. We don't allow them to bring things into the bathroom with them. And then we don't do a urinalysis drug screen, a little dipstick or something like that. I actually am a strong critic of programs that just do that. If you're going to do that, then you still need to send the sample off to a lab. You need to have it sent to a lab so that confirmatory testing procedures can be used and so that a toxicologist can sign off on the accuracy of the test results and what it does or does not mean, because they are the experts in that domain, not us. We're not experts at interpreting urinalysis drug tests and ruling out other contributors to positive results and things like that. That's what a toxicologist does. So they need to do their expert piece and we need to do ours. If you're just collecting a sample on site and using a dipstick, that's simply a screening test. And I would not be making a major decision or allowing those results to significantly influence a clinical decision. There's not enough. Now, you can do that very inexpensively. We use a lab where we collect a specimen and we send it off to the lab. The actual test itself only costs like $7 for the confirmatory testing and everything. Then you have your shipping cost and you have your materials cost, but it's not expensive stuff to do a full panel drug test with confirmatory testing and have a certified lab provide the results and a toxicologist sign off on them. So I encourage you to look into those resources. I also talked to them about how I will be checking public records to confirm their self-report about their legal history. Very frequently, clients underreport their legal history when they complete the biopsychosocial questionnaire that I have them complete in the office before I even meet with them. So I make sure they know that I'll be checking records, and then I ask them later on if they think anything will show up in my search that they haven't already discussed with me. I word it that way to help them save face, because I'm not going to say, were you honest when you completed your evaluation and thorough, or did you hide information or conceal information or hold back? I'm not going to say that. I'm going to say, I'm going to remind them that I'll be checking public records, and then I will ask them later on Do you think that when I check the records, anything might show up that you haven't already talked to me about? Maybe think about that for just a moment and see if anything comes to mind. They're much more likely to tell you about things when you talk to them respectfully, I believe. So I also again ask them if they understand the procedure for the evaluation and if they have any questions, and with that information in mind, if they'd like to go forward with the evaluation. Like I said, I mentioned that, given that I'll be doing public records, is there anything that'll show up? And given that I'll be collecting a urine specimen, do they think anything will show up in the test that they haven't already told me about? Then we move into the part of the evaluation where I start asking them about their presenting situation, what brought them here for the evaluation. Now, a little disclaimer here. I've shared with you how I do informed consent, but keep in mind that state to state, there are different exceptions to confidentiality sometimes and different laws that have to be contended with. So ultimately, it's your responsibility to know that the informed consent that you're providing is consistent with not only federal laws and guidelines, but also with your own state laws. Now, I originally was taught that forensic evaluations could not be considered HIPAA regulated information. However, multiple forensic experts have told me that that's not the case. And then in reading the professional literature, I see there's quite a debate out there. And that in some cases, forensic evaluators are getting in trouble for not adhering to HIPAA. So I would encourage you to assume that the information you're collecting is HIPAA regulated and act accordingly to be on the safe side. So when we in the clinical interview talk about the circumstances related to the referral, we're asking about who, what, where, when, and how. So what happened that brought them here? You use your active listening skills. Fortunately, most of you were trained as therapists, so you can use those active listening skills while they tell their story. Let them tell their story, and ask them open-ended questions, and be interested and be genuine. And what I do is at the end of their story about what got them here, I like to read back my account of what they've told me and retell the story and see if they think I've got it right or not. Also, want to make sure that you have verified the exact verbiage of what the referral source is looking for. So if it's a court order for the evaluation, read the court order. What exactly does it say you're supposed to be doing or not doing? I have sometimes what the client tells me the evaluation is for, or even what the attorney tells me it's for, is different sometimes than what it actually says in the court order or in the terms of probation or whatever. So make sure that you're paying close attention to that exact verbiage and that you stay focused on those specific things that the court is asking you to do, or the probation officer or whoever else. So now let's get into the diagnostic interview component of the clinical interview. We'll start with our code of ethics. Mental health counselors do not provide written conclusions or forensic testimony regarding any individual without reliable information adequate to support any statements or conclusions offered in the forensic setting. The forensic mental health evaluator expert does not diagnose anyone that was not seen during the evaluation process. So in some rare scenarios, people are actually providing opinions to the court on somebody that they've never even interviewed. Now, the substance use disorder categories in the DSM-5, first I'm going to give you kind of a simple rule that maybe makes things a little bit easier with substances. That rule is, or that phrase is, uppers, downers, and all-arounders. There's actually a textbook that some professors have used for undergraduates and graduates called Uppers, Downers, All-Arounders. And it simplifies your drugs of abuse into 3 categories. Uppers are stimulants. And in the DSM-5, there are 2 categories that would fit into uppers. That includes stimulants, which consist of amphetamine-like substances, and cocaine. And the second is tobacco, as also a stimulant. The second category is downers, your central nervous system depressants. They include, in the DSM-5, the categories are alcohol, opioids, and sedative hypnotics or anxiolytics. And then there are all-arounders, which is kind of your miscellaneous other category, because it can include substances like cannabis, which are combinations. Cannabis is an upper because it increases heart rate. It's a downer because it slows central nervous system functioning, but it's also a mild hallucinogen because it distorts perception in space. Hallucinogens is another category for all-arounders, inhalants, and then your other or unknown category for substances that we don't have an official category for yet in the DSM, like synthetic marijuana. I argue that doesn't count as cannabis because the chemical composition of synthetic marijuana has so many other things in it that produce very different results than cannabis usually provides. And then kratom is a new one because we're still getting information and research, but I have already been meeting with clients who have had very severe kratom-related problems, including emergency department visits. So I imagine that as we continue to collect data going forward, we'll continue to see more problems connected to kratom and similar substances that are currently legal in most places. Although, by the way, the FDA has now officially said that kratom is an opioid-like substance, and they're paving the way for some regulation in that area, so we'll see what happens. Now, you need to obtain a thorough substance use history. So for each category of substances, you're going to ask about what was used, how it was used, how much, when it was used, and what the client liked or disliked about use. That's one way to get them to talk about both the benefits, perceived benefits, and drawbacks of their substance use in a very comfortable conversational way. Pay attention to DSM-5 verbiage. When you see phrases or words like clinically significant, recurrent, markedly, continued, often, persistent, and great deal, those words and phrases denote that this is stuff that has to keep happening or be happening at high levels or with serious implications. And what I see is sometimes we over-diagnose or over-pathologize based on isolated events or experiences because we're not paying attention to this verbiage. For each symptom that the client endorses from the DSM-5, find out when it was happening, how often, and for what substances. And if the client tells you yes to a question, dig deeper, get them to talk more, and use your active listening skills and ask lots of questions, especially when possible open-ended questions, to get them to tell you more about those experiences. Now, if we look at the actual diagnostic criteria, we start with a pattern of substance use leading to clinically significant impairment or distress as manifested by at least 2 of the following 11 symptoms within a 12-month period. So let's break that down and unpack it because that's a lot. Impairment or distress, and then what makes it clinically significant. I should start with this actually. The word pattern denotes that this cannot be an isolated event. So if you had a 16-year-old that drank alcohol for the first time at a party, and then they got into their car and they hit a mailbox on the way out and the police got called and they had a DUI, that's not enough to diagnose an alcohol use disorder because that is a one-time experience. That doesn't establish pattern, it doesn't establish recurrent, so keep that in mind when you ask questions. The first symptom is the substance is often taken in larger amounts or over a longer period than was intended. Well, what I've given you is examples of questions that you might ask to find out if that symptom is met. Because if you literally read the diagnostic criteria verbatim to a client and ask them yes or no, they're pretty much always going to say no. Because these are very wordy symptoms that sound very serious and a little bit overwhelming sometimes. Use more conversational language. Like, have you ever thought to yourself something like, I'm just going to spend a couple hours at the bar today, but you find yourself staying a lot longer? And if a client says yes to that, you can ask, does that seem to happen a lot of times? About how often would you say that happened? That is a lot better than, have you often used a substance in larger amounts or over a longer period than was intended? That's not going to get you as valid of a response from clients. So these are examples of questions that you can or should be asking. The second symptom is a persistent desire or unsuccessful efforts to cut down or control the use of the substance. Pay attention to the word or. When you see or instead of and, that means you can have one or the other instead of you have to have both. So either there's a persistent desire or there are unsuccessful efforts to cut down or control. So examples of questions might be, have you ever quit using it? When did you do that? Do you know why you wanted to quit or what brought you to quitting, or what was it like for you to quit? Did you eventually go back to using? What do you think happened that brought you back to using? Those are more casually worded questions. Have you ever tried to scale back? What was that like? How did it go? When was it happening? Why do you think you wanted to scale back? And see how we're trying to be much more casual and comfortable in the way that we talk about things so that it makes more sense to clients and so that they can feel more comfortable in being open with us. Take the symptom: a great deal of time is spent in activities necessary to obtain the substance, use the substance, or recover from its effects. That's an intimidating verbiage for a client. But you can ask questions like, have you ever spent a few hours or more in one day getting or using a substance? Those are questions that people will feel much more comfortable answering and that they'll understand more. Craving is actually pretty straightforward, I think, but we're not just talking about a desire or interest in using something. We're talking about a strong desire or urge, a compulsion almost. So the next symptom is use resulting in a failure to fulfill major role obligations at work, school, or home. Well, again, that's an intimidating item for clients. So you might break it down more to questions like, when you were in school, did you ever skip school to get high? And have you ever gone home after school, maybe smoked some weed, and then you didn't feel like doing your homework or like studying? When all that was happening, what were your grades like? Did you notice your grades start to change as you started smoking? Those are things that people will tell you more. People tell me no to the symptom in the DSM-5 verbiage, but then yes to all of these follow-up questions, and that tells you something. Or back when you were drinking a lot, did you notice that you didn't keep your house as clean as usual? Have you ever called in sick because of a hangover? And again, if they say yes to these, you don't stop there. You need to find out, is it recurrently happening over and over? And is that producing significant problems? If they've called in sick because of a hangover from work, okay, but did that happen several times? And did they get into any trouble? Or were they less able to meet their performance review expectations because of it? That's the stuff you need to eventually get to. It's not enough to know it happened. We're getting at impairment or distress. The next symptom is persistent or recurrent social or interpersonal problems. So you can ask them things like, have you ever been drinking and then said something mean or nasty that you probably wouldn't have said had you not been drinking? You'd be surprised how many people say yes to that who say no to the social interpersonal problems verbiage. Have you ever been drinking and then you got into a fight you probably wouldn't have gotten into had you not been drinking? Have you and a significant other ever argued about how much you use or how much money you spend on it or anything else about your drinking or your drug use? Has a significant other or a family member ever said they were concerned or unhappy about your use? I also ask people, do you think you've ever lost a friend or a relationship because of your use? Eventually, they often will open up about those things as well. I also give them examples of things. So here's an item: social, occupational, recreational activities being given up or reduced because of using a substance. I'll tell them examples of things other clients have told me. Like, a guy told me he used to run almost every day, then he started smoking cigarettes, and then he stopped running. But then he noticed that when he quit smoking, he started running again, but he stopped again when he started smoking again. Have you ever had an experience like that? Or a guy told me he quit playing soccer and football in high school because he knew he couldn't pass a drug test. And then I asked him if football and soccer was really important to him, and he says, yeah, actually, I really regret dropping out of those things. Or a lady once told me she went to yoga every Sunday like it was church for her, but then she started drinking on Saturday nights and she stopped going to yoga. And she doesn't think she would have stopped if it weren't for drinking on Saturday nights. So you can give examples too. That helps clients to start thinking sometimes. It also normalizes to some degree these experiences. The physically hazardous situation criterion, you could ask about not have you driven while you were impaired under the influence of a substance, but have you ever driven when you could feel high or buzzed? When was the last time that you think you drove when you could feel high or buzzed? I use that one when I've already got evidence that they've done it. Then I skip have you ever and I go straight to when do you think was the last time that you drove when you could feel high or buzzed? And they'll tell you all about all kinds of experiences sometimes. Do you think you've ever driven after you've been drinking, and then if you'd happened to get pulled over by a cop and you had to do a breathalyzer, you probably would have blown high enough to get a DUI? You'd be surprised how many people say yes to that, but no to whether they drove in a physically hazardous situation. Have you ever been hunting when you were drinking? How about boating, bungee jumping? I say that one just to be funny sometimes. Have you ever been doing work around the house when you were drinking, like maybe roofing or something like that, using a heavy machine or a blade or something along those lines? So again, we want to give them some examples and ask more specific questions. this item about persistent recurrent physical or psychological problems, you can ask about any medical concerns they have, any prescriptions they're using, whether doctors or other health professionals have ever suggested they quit or cut back. You can ask about whether they sometimes feel anxious or depressed or angry when they use a substance or after they get done using it, what that's like. For marijuana, I ask people, when you were smoking daily or almost daily, did you notice that you would tend to get more lazy and lethargic and not feel like doing things and then maybe not as accomplish as much as usual? Because that's amotivational syndrome, and that is a psychological problem connected to marijuana use. Tolerance is when the client is using daily or almost daily and then over time to get the same effect they used to get from less. So here are some examples of questions you can ask about that. You can go back and look at these on your own later if you want to. And with the withdrawal symptom, I encourage you to actually go into the DSM and look at the withdrawal diagnosis for that particular substance, and then see if when they were withdrawing, if ever, which of these symptoms they were experiencing specifically, so you know whether it was really withdrawal or not. So before we do this polling question, I guess I'll pause here for a moment and ask, Norm, do you see any questions that we need to get to?
We have three now.
Okay.
Tanisha asked, how does a signed court order from a judge allow to disclose confidential information? And would the client need to provide a consent to allow disclosure information?
I'll answer that by saying my understanding is under HIPAA, for example, if a judge issued a court order that essentially required the counselor to share information, then even if a client hasn't consented to it being shared, in that scenario, you would have to provide information. Unlike a subpoena, if it's a subpoena, that's not the case. A subpoena is not a court order from a judge. Norm, you may want to mute yourself for a moment there because we're in a lot of background. But if it's a subpoena, that's simply a request from an attorney that you do not need to, you need to respond to it, but you don't provide information under 42 CFR Part 2 anyway, unless the client has authorized you to. But if it's a signed court order from a judge, my understanding is both for 42 CFR Part 2, federal legislation, and HIPAA, that you would probably need to provide information in that scenario. And I don't know, Norm, if you have a different understanding that you'd like to share about with that item.
I agree with you. And, you know, Mike Holler and I, when we get together, we do the same thing. If we feel it's confidential and could be injurious to the client or patient, we insist that if the judge orders it, we give it to the judge to disclose, and we don't give it to anybody else. We let the judge make that decision who they're going to give it to.
All right. So our next, you have two more questions before we go on to the next point.
Tanisha also asked, how do you feel about instant drug tests? I think you did discuss that earlier.
Yeah, if you're going to do that, then again, you still need to send it. Let's say you do an instant drug test and you get a possible false or possible positive or negative. You still should send it off to a lab then if you're going to do that, and let the lab analyze it and confirm the results. Because with dipstick tests, you can have false positives and false negatives all day long. They're not as reliable as your lab tests for confirmatory procedures. They're just a screen, not an actual full test.
The last question is from Ken Hurd, one of our certified members. How long does it usually take you to do a thorough ALC/SUD evaluation?
Good question. I feel like I've really got it down to an art and a science. So I can tell you the minimum, and I can tell you that sometimes it's a lot more than a minimum. First, they're going to, separate from meeting with me, they're going to be taking tests in our office that I will not be spending time with them on. We have our, basically our psychometrician do that, or office staff who are trained to give them the test and give them the instructions and make sure they have an appropriate environment and that sort of thing. So they do the tests, and that could take a couple hours because in addition to the written test, they're filling out, you might want to mute again, Norm, for a moment. In addition to the in-depth test, they're also doing a full biopsychosocial assessment template. So they're filling out a whole packet of biopsychosocial information and doing written tests before I even meet with them. If you include that time, that's probably a good 2 hours. If you don't include that, because I'm not spending time with them, then it's 0 hours. But then the actual clinical interview is going to be a minimum of 2 hours for me. It takes me at least 2 hours to do a substance abuse eval. In more complicated cases, it might be 3 or 4 hours of me talking with the client, but usually I am able to get it done in 2 hours. Then after that, there is the records review, and that is so variable because if you have a client with an extensive criminal background, for example, with lots of treatment records and lots of hospitalizations and things, you may be looking at several hours. If your client who has none of that, then it might be very limited time that you're spending. So it all depends on what records are out there and which ones I get and how lengthy and big those records are. Then the next component is the collateral interviews. So in some cases, I'm doing very little with collateral interviews, maybe a 15-minute interview with this person, and maybe another 15 minutes with that person, maybe half an hour. But in other cases, I might be doing as much as a few hours of collateral interviews. So I would say on average, though, my actual time interviewing the client or others and reviewing records is probably, I would guess, 4 or 5 hours maybe on average. But it didn't used to be that way. I feel like I've really got it down to a science at this point. Is that all the questions we have for now, Norm? All right, you're probably muted, so we can't hear you right now, but I'll assume we don't have any other questions for now and move on. And we'll get to another polling question here. So let me go in and launch it. Our next polling question is, true or false, withdrawal and tolerance do not count as symptoms of a substance use disorder if the client is taking legally prescribed medication. So I'll give you a moment to chime in and see what your opinion is on that item. All right, we'll go ahead and close our results out with 75% of you having chimed in. So 79% said that is false and 21% said true. Now, I don't feel very good about the answer to this question, but the honest answer is true. The DSM actually has built into it specifically an exception where you cannot count tolerance or withdrawal towards the symptoms if the client is using one of the either a sedative, hypnotic, or anxiolytic, opioid, or stimulant medication as prescribed consistent with the physician's orders. So there is a bit of a qualifier here. In other words, if your client's being prescribed hydrocodone, for example, or oxycodone, and they're taking it as prescribed, they're supposed to have tolerance and withdrawal if they're regularly taking it, so you're not allowed to count that as a substance use disorder. I have mixed feelings about that because sadly, if we had a world where I believed physicians were always prescribing medication in a way that would not produce significant problems for clients if taken as directed, then I'd feel better about this exception. But sadly, I don't think we live in that world, even though many physicians do a great job with this, many do not. So I have mixed feelings about it, but I want you to know that that's what the DSM says. So for your diagnosis, we talked about how you determine what symptoms have been met for what substances and when. Then you diagnose the substance use disorder for substances that have 2 or more of those symptoms within the same 12-month period. Your next step is to specify if they're in remission, and then you specify if they're in a controlled environment, and finally, you specify their current severity. So you're not done when you found out what symptoms have been met. That's not the end of your diagnosis. If it's 2 or 3 symptoms in the same 12-month period, it's mild. 4 to 5 is moderate, and 6 or more is severe. So remember, there were 11 symptoms, and then the number of symptoms in the same 12-month period is what you use to ascertain level of severity at any point in time. Now, usually you're most interested in the most recent 12 months. So it would be in the past 12 months, how many symptoms for what disorders? Or in the last 12 months of their use could be another way to think of it. So our next polling question is about remission status and what it means or does not mean. Oh, I just noticed here that you guys haven't been seeing the last couple slides, so I'm sorry about that. I forgot to close the last polling questions so you could see them, but you have the slides, so it'll be okay. So true or false, in DSM-5, remission is determined by how long the client has maintained abstinence or sobriety. So in other words, how long has it been since they last used? True or false? We'll give you a moment to chime in. And with about 70% of you having chimed in, actually looks like 75% or so of you, we'll close this out and share our results. 89% of you said true and 11% said false. Again, I'm going to go with the minority on this one. That's why I launched this polling question, because it's often answered incorrectly by clinicians. Literally, remission is not determined by when the client last used a substance in the DSM-5. So that 11% of you would be right. Here's what the DSM does say we use to determine remission. Now, I get that in the recovery environment, in the recovery culture, we're very big on when did the person last use, but technically the DSM doesn't look at it that way. The question is, when were any of those 11 symptoms last experienced? So hypothetically, for example, if a client in January 2018 met the diagnostic criteria for mild alcohol use disorder, but going into 2019, they're still drinking, but they're not experiencing any of those 11 symptoms, then technically they're in remission even though they're still drinking. Now, the reality is that doesn't happen very often. Most of the time, if they have met the criteria for substance use disorder and they're still drinking or using, then eventually these 11 symptoms are going to be happening again. But I just want you to know that that's not technically how we determine remission per the DSM.
Aaron, there's a problem with the slides. They're saying they're only seeing the quick poll, not the slides.
Oh, good. Thank you for letting me know, because I forgot to hide the results again. So hopefully you guys can now see the slide. So after the full criteria for substance use disorder was met, if none of those 11 symptoms have been met for at least 3 months, but less than 12 months, then they're in early remission. Now you have an exception. They can still be experiencing craving, but be in remission. So aside from that symptom, the other 10 symptoms, have they experienced any of them in the past 3 months? And if no, but less than 12 months, then it's early remission. If it's been 12 months or longer since they experienced any of those symptoms other than craving, then we would call that sustained remission. So hopefully this helps to clarify the issue of remission. Now, Norm, I just saw the question button lighting up, so I imagine this might have triggered a question. Do we have something?
Yes. How do you determine fee for the SUD evaluation?
Oh, okay. So my short answer would be, you look at what is the going market rate for the time spent on an evaluation. You think about how much you think you should be being paid per hour, and then you calculate how many hours you intend to be working with the client, and that might give you a good sense of cost. Now, for me, quite honestly, I undercharge, and I won't in the future, but for right now I am. And the reason I am is because, sadly, this is a highly saturated, highly populated county, and there are unfortunately many programs that are providing low quality substance abuse evaluations for extremely low prices. I mentioned earlier, one place right down the road is doing court-ordered substance abuse evaluations for $75. That's ridiculous. And they're not providing a quality evaluation. But what happens is clients, and especially in this area of specialization in my region, a lot of these clients don't have a lot of money. So they're price shopping the list that the court gives them or the probation officer gives them, and then they're going with the lower cost places. So I charge a minimum of $350, but sometimes I'm charging a lot more than that because it's a more complicated case that needs more time reviewing more information, but that's my minimum. So compare me, a minimum of $350, to a place down the road that does $75, and you can see why many clients are choosing the $75 place. I still get plenty of substance abuse evals though, because attorneys refer clients to me who they want to have a quality evaluation that will work well for them in the trial or in the court proceeding. So it's not like I don't get referrals because of that. Now, if it's a substance abuse and mental health eval, then my minimum is going to be $750, but usually it's going to end up costing a lot more than that actually, depending on the how intricate the case is. What I see most of the time though is most places are charging thousands of dollars. Most of our forensic evaluators are charging thousands of dollars per evaluation. So I consider the costs that I charge here very low. It's just that we have lots and lots of competition here with low paying evaluations. So let's get back to the slides here then. Next, after you've determined remission status, you have to add a quality if they are in remission, but they're in an environment where they have limited access to the substance, then you tack on a specifier in a controlled environment. If they're in a jail or a prison, a halfway house or transitional house or residential treatment program or hospital, those might be good examples. You do that because it's a different matter when they're not using, but it's because they're in a controlled environment, than when they're not using and they're completely out there on their own, even though they presumably could much more easily access the substance. That tells you something different. The next thing you determine is whether they are on maintenance therapy. This is specifically for opioid use disorder. And this is if somebody's being prescribed an agonist medication like methadone or buprenorphine, then you'll add on maintenance therapy at the end. Unless they have a problem with that maintenance therapy, like they are actually experiencing, that is the drug that they're having the problems with, then you may decide not to do that. Now, a resource that I will give you is, and I'm going to show you it right now, it's in a folder that we, again, are giving you access to. These are the items in that folder, and that link, although it'll look differently to you when you visit the link. One of the items I have here is my DSM-5 substance use disorder checklist. So I've taken the 12 symptoms and I have this on my iPad in front of me when I'm meeting with clients and I scribble on it with a stylus. When I ask them questions to help me determine if symptom number 1's met, if they say yes, then I'm gonna put a check mark here. Actually, let me make this even easier and actually grab a pen here. If they say yes to symptom number 1 or one of my variations of that question, I'm gonna check it off. And then I'm gonna indicate what substance. Let's say it was, man, it's hard to write with this versus my iPad. It's almost impossible actually. THC. And then I'm gonna say, okay, they most recently experienced it now. So I know what I need to know about that symptom, and I'll do that for all 11 symptoms. Then I go here and then I count up for each. Let's say we had 3 THCs, then I know, okay, that's a mild THC use disorder, or mild cannabis use disorder, in other words. Okay, I can't do this, but you get the idea. And then let's say that I see 4 alcohols in the same 12-month period. Then I'm going to click moderate and I'm going to write alcohol right here and so on. Then I next need to move into, are they in remission? So I'll look at the time frames, and if I see anything that's 3 months ago but less than 12 months ago, then I'm going to know that's early remission for, let's say, alcohol, for example. And then I'll write alcohol right here. But if I see that it was more than 12 months ago, the last time they experienced any symptoms for, say, marijuana, for example, then I'm going to check off sustained remission, and I'm going to write marijuana right there, or THC. Then I ask myself, are they in a controlled environment or not? And then do they have an opioid use disorder? And if so, are they on maintenance therapy? And what is the medication that they're taking? Here's a reminder here that symptoms 10 and 11 do not apply if the client is taking a prescribed medication as ordered. And then I put in parentheses what I consider to be as ordered. So you have that tool available to you now that you can use. Let's get back into, so we're not going to do the practice scenario because I tested it, and unfortunately the video is not working well with the webinar software. However, if you wanted to on your own, if you had cable access to VH1, then you can go to VH1's website. You can actually just Google Celebrity Rehab Season 1, Episode 1. And you could go in and watch a video clip of when they introduce the various people, or any season for that matter, introduce the very people in their stories, and you can listen to what they're saying and decide what symptoms you think you at least have yellow flags for based on what you're hearing. but unfortunately, we're not going to be able to get into that today. So let's move on to the biopsychosocial assessment. Now, again, I give them a packet that they complete in the lobby with all the biopsychosocial information before I can see them. It's down on my interview time. It gives me a lot of information ahead of time that I can review and then highlight the things that I want to ask follow-up questions about. You can use a questionnaire, like I give you a link to my questionnaire that I give people in the lobby. You're free to modify it and make it your own if you like. You can create your own, or you can use a more structured tool, which is probably a good idea because then you can say in your report, I didn't just come up with this stuff. I used a structured tool that has been normed or has been a part of research projects or whatever. I like Texas Christian University's forms. They have some really good psychosocial forms that are available for free. Also, the Addiction Severity Index is available for free, and that has a bunch of psychosocial questions in it. But this one, Quick View Social History, costs money per administration because it takes their psychosocial history and it puts it into a narrative format for you. Now, those of you who are CFMHEs know that Dr. Hoffman has also made available to you another tool that's actually an old DOS program tool that works pretty well that you could use for free. So if you need that information and you are a certified forensic mental health evaluator, get in touch with us and we'll give you some information on it. So what are the ASAM treatment criteria? Well, first of all, the treatment criteria basically goes back to managed care, and it goes back to the 80s and 90s when there were different models that were emerging to help us to decide, but how do we objectively determine what kind of treatment a client needs? I love the ASAM treatment criteria. They are the gold standard in the field. In fact, many insurance companies and even some legal authorities require you to use their model when you're determining level of care for clients. If used appropriately, it can be a valuable tool. Unfortunately, sometimes it is abused, but that's another webinar maybe. So one thing I like about it is it's very holistic. It gives you 6 dimensions that you need to explore with the client. The first is acute intoxication and or withdrawal potential. So you need to know about their substance use history, their past experiences with withdrawal, and whether they might be at risk of withdrawal in the near future. Because if, for example, they're withdrawing from a benzodiazepine or from alcohol and they have a pretty heavy and prolonged use, in the past they've had withdrawal, then you're not going to want to have them in an outpatient treatment. You're going to want to send them to a detox program because they could have a medical emergency when they're withdrawing on an outpatient basis. And then not only has your client been substantially harmed, but you could actually be liable for what you're doing. You made a bad judgment call on what kind of care they needed. Dimension number 2 is biomedical conditions and complications. So here you're looking at, do they have any co-occurring medical problems that need to be addressed or taken care of? So let's say you decide that they need residential treatment, but they're on dialysis. Then you're going to need to make sure that they have access to a residential treatment that can accommodate their medical needs for the dialysis treatment. Dimension 3 is emotional, behavioral, or cognitive conditions and complications. And here you're looking at, do they have any co-occurring mental disorders or neurocognitive disorders? For example, if they have a severe neurocognitive disorder, are they really going to benefit much from talk therapy? Or would they need more of a, say, a behavioral approach or something along those lines? If they are acutely suicidal, then we're not going to be doing outpatient right now. We're going to be getting them to a crisis unit. If they have pretty severe depression and they're withdrawing from their alcohol, they really ought to be in maybe a residential program that can accommodate detox and can co-address the depressive disorder through psychotherapy with licensed mental health practitioners, or maybe with medication. So they should have a psychiatric component in their program as well. So these are the things you're trying to tease out with Dimension 3. Also, are they extremely violent or aggressive or something along those lines? Because there are going to be certain programs that won't be able to work with that. Dimension number 4 is their readiness to change. And here we draw on the Prochaska stages of change. Which stage of change are they in for, say, their alcohol use, for example? Are they pre-contemplating, meaning total denial, basically, lack of awareness or insight? They cannot or will not seriously consider the need for change. The next step is contemplation, where they're basically saying, maybe I do have a problem with my drinking. Maybe I do want to change. I'm willing to seriously consider that. Preparation would be they know that they've got to do something. And maybe they're not quite ready to do it, but they're looking into how they could pull it off, or they're weighing out their options, or they're exploring some possible ways to address their problem. Action is when they're actually actively implementing a behavioral program of change. And then maintenance is when they have gone for a substantial period of time with that change such that it's now the new normal and they're well adjusted to it. And the relapse risk is therefore lower. As a rule of thumb, about 6 months is when Prochaska and colleagues say that somebody's usually in maintenance. Keep in mind, for the first 90 days of abstinence, people's brains are still really just trying to get a sense of balance. And then there's relapse and recycling. So which of these stages is the client in? That will help you. You basically are identifying that in dimension 4. Dimension 5 is their relapse potential. So here we're looking at, do they have a strong history of trying to stop but not being able to? Do they have very little control over their use? Do they tend to relapse over really small triggers and things like that? Those would be, are they actively in a state of perpetual relapse or periodically relapsing in the here and now? If they're in outpatient treatment right now, but they're periodically relapsing and not quite getting their footing, for example, then maybe they need a step up level of care and so on. Then finally, we have dimension 6, which is what's their recovery environment like? So do they have social supports? Do those supports support them in maintaining or establishing abstinence? Do they support them in their recovery? Do they live with people that they have very conflicted relationships with? Are they in an environment where they have easy access to substances? Does their drug dealer live 2 doors down? Those kinds of things. Do they have are they involved in a support group? Do they have a sponsor or a fellowship? Those are things that you're looking at with dimension 6. So you can see how holistic this is. And in each of these dimensions, you basically are determining where they're at and what kind of care they would need. Again, we have a tool to help you with this. Actually, it's not our tool, it's the American Society of Addiction Medicine. If you obtain their manual, which I have right here, the ASAM criteria, published in 2013, in here they have something called the matrix for matching adult severity and level of functioning with type and intensity of services. Couldn't be any longer than that title. But in each dimension, you have a number that you assign that denotes how intense their risk is. Oops, keep messing stuff up here. So for dimension 1, acute intoxication and or withdrawal, a risk rating of 0 means you're saying they don't have any withdrawal issues that would warrant any need for special assistance. But as you move up the risk ratings, you'll see that the description of what's going on with the client changes and that their needs therefore change. And this will help you determine what kind of treatment they may need. So I really find that helpful. Now, there are different levels of care in the ASAM model. So you start off with early intervention, which is for individuals who don't have a diagnosed substance use disorder. Maybe they're at risk. You have identified risk factors. So you might do education or prevention with them. Or maybe they're so defensive and you don't have information to be able to diagnose that you maybe do some motivational interviewing or something along those lines to help them figure out if they even have a problem or not. Then the next level is outpatient. So there is generally a diagnosis of a disorder in outpatient. It can also be used, but they don't have severe treatment needs. They're pretty low risk of relapse. They've got good supports. Maybe it's somebody who's in remission and they just need a step down level of care from a higher level of care. Or maybe it's somebody who just has some minor problems with substances, but they seem to have a good amount of control and they got a lot of coping strategies and supports, and they might do well with standard outpatient. You can also park clients who are ambivalent about change in outpatient. But when you're in a forensic evaluator, you're not letting that sway your opinion. That's more if you're a treatment professional and you don't have leverage and the client's not willing to do the higher level of care that you think is appropriate, then you might do outpatient if it's physically safe to do so. and do motivational interviewing to help them explore their ambivalence about getting the help they really need. Then we move up to intensive outpatient, which is at least 9 hours of therapy a week. Usually we're seeing moderate to severe substance use disorders here. Then we move up to partial hospitalization or day treatment, which is a minimum of 20 hours per week, which is basically you saying that the client is just a hair below what they would need to be hospitalized or to be in residential. And then you move up to various forms of residential care, depending on what the client's needs are in terms of co-occurring disorders and so forth. So again, the resource is the ACAM treatment criteria. That's the resource I'd recommend using for that. Let's get into our records review now. So first we have legal and judicial records. So what is the exact nature of the client's current charges or current case? What specific questions does the referral source want to have answered in your report? Do not stray from that. So if they're saying, we only want to know A, and you give them A, B, C, D, and E, they might actually, opposing counsel might actually use that against you and say, why are you talking about all this stuff that no one asked you to do? That shows maybe you're biased and you're wanting to use this as an opportunity to explore all kinds of other things that you have an agenda about with this client. So you stick to what you're being asked to do by the referral source. If there's a court order, you only do what the judge is asking you to do in the court order. You also will want to explore who the report goes to. Does it go to an attorney? Does it go to the client? Does it go to the judge? And what are the possible implications? Does it go to a probation officer? Who does it go to? And then is there any history of substance-related legal problems in their background? So sometimes clients will give you just the charge that they're currently dealing with, but they don't tell you, by the way, I've had 3 other DUIs in the past 15 years. If you knew about those 3 other DUIs, then you already know about another symptom that they've met, which is recurrent use in physically hazardous situations. So maybe they're denying that symptom in their interview with you, but their legal history with their breathalyzer results and so forth show a different story. So in that scenario, the record review will help you to add that symptom even though the client denied it initially. And then does the client underreport any legal history during their clinical interview? So you're looking for, are they underreporting and are they minimizing or not? Now, how do you find public records? Well, you start with the records you get from the attorney or the court. Then maybe you go to that county's public records online database and see what else pops up for this client. Or you do the arrest inquiries for your region or your county. But that won't tell you if in other areas they had arrests. And I historically have had a hard time trying to figure out, well, how do you get that information? The best I could come up with is to use one of those cheesy online public records search subscription systems. Like I use Truth Finder, it costs me like $20 a month to have a subscription to it. And it automatically searches like all the different online databases for information about your client. However, there are a couple caveats here. One is you would never assume that what it tells you is true, because those search engines can have errors. They can have people whose information is similar to your client, but not your client, for example. So if you get a hit when you use that, then you look at where's the source. And let's say it says Hillsborough County Public Records. Then you go to Hillsborough County Public Records database, and then you search there. So all it does is narrow your search down for you, but then you still have to go to the original source. And then what I always do personally is if I find something that the client didn't report, I tell the client, hey, I found this. Do you know about this? Can you tell me about it? They almost always will tell me about it and admit to it. So then I've got good reason to be using it in my report in that scenario. So then you also want to look at past treatment records. Are there additional symptoms that they reported to evaluators in the past that they never reported to you that you can use as part of your diagnosis? What was their progress like in treatment or their prognosis? What was the nature of their discharge? So do they tend to leave without successfully complete? Like if a client tells me, oh, I'm good now, I haven't used in a long time, and I did this treatment program and I completed it successfully and did everything I was supposed to do. But then I go pull the records and I found out they were discharged AMA against medical advice, and or they were completed but recommended for a level of care that they never pursued. Then I'm now doubting obviously what the client is telling me I'm finding contradictory information that I can factor into my evaluation. What was their participation like in treatment? Were there co-occurring disorders that they weren't telling you about in the interview? And what have been their relapse triggers historically? Because if you know what their triggers have been historically, you can ask them, how do you deal with these triggers in the here and now? And that might help you to get a sense of their relapse risk for dimension 5 on the ACM treatment criteria. Go into medical records like their primary care physician. I tend to pull primary care physician records because I'm looking for, do I see an alcohol-related stomach ulcer? Do I see high blood pressure and high cholesterol? And the doctor's been saying, yeah, to cut back on the beer because you've been drinking too much of it, but the client didn't. Or do I see that they tested positive for illicit drugs in a urine specimen that a doctor collected, but they told me they never used that drug before? Do they take any medications that interact negatively with alcohol or other substances that they're using? And do they comply with what medical professionals recommend? Are they underreporting to medical professionals about what is really going on with them? Those kinds of things can all be helpful. Sometimes that's made a big difference in the evaluations I've done, and it will help you, especially with the DSM criterion, about whether they continued their substance use despite knowing about medical problems that the substance use was either causing or contributing to. Then you go into your collateral sources. So these are interviews with other people who may be able to tell you information about what the clients told you. So I'll tend to ask people, well, do you observe a client drinking, and how often do you think he drinks? What do you notice when he's drinking? Have you had any concerns about his drinking? Those kinds of questions. When was the last time that you saw him drink? That information can supplement what the client's saying. And it's kind of nice when it all lines up with what the client's saying, but obviously that's not always the case. Also, previous therapists that the clients worked with sometimes can make for good interviews because they'll give you a lot of rich information that you might find helpful in your report. Now, of course, you have to have release forms signed by the client to do these things, so keep that in mind. Looking at our code of ethics as we're about to move into testing here, so we have to choose our tests wisely and stay updated with our tests and have a rationale for why we're using a specific test. And we must be competent in administering and interpreting that test. So the two that I use the most in my evaluations are the SASI-4, or for adolescents, the SASI-A2, or there's also a Spanish version. Because unlike many substance use tests, this test helps to detect subtle attributes of addiction. So for some reason, there are items that people with addictions tend to answer differently than the rest of us for reasons we don't fully understand. And the SASI-4 has a scale for that. It also detects defensiveness and inconsistencies, and ultimately whether there's a high or a low probability of the client having a substance use disorder. This is the gold standard test for forensic work, in my opinion, but I supplement it with the Maryland Addiction Questionnaire. Now, you would never use the MAQ by itself because the MAQ can only be used if you are assuming that the client does have a substance use disorder, because that's the population the test was designed for. So if I've already concluded they have a disorder, then I use this test to help me figure out what might be their treatment needs, because it will tell me about things like how motivated they are, how resentful they are. Do they have social anxiety that might make group kind of hard for them without some individual work up front? Do they have a lot of emotional distress and they might have a co-occurring mental disorder? Do they think they have a lot of control over their use? Are they reporting a high level of craving? Do they think they have some cognitive impairments? So it's really helpful in that sense. The behaviors and attitudes drinking and driving scale is great for instances of driving under the influence or DOT evals, except it's a self-report tool, no validity scales. So people can BS their way through it. And the same with all these other tests. So maybe you'll use these as a supplement, but I would never recommend using them alone because none of them have validity scales. So clients can just lie all the way through it. And there's really no way to know for sure. You can look for their inconsistencies between what they said in these tools and what they said in the clinical interview to build a case for maybe they're denying or minimizing, but they're limited in their efficacy. Now you can find lots of screening tools for co-occurring mental disorders at either of these two resources if you would like. And if we have time, then I might show you how to use this particular tool, because a good substance abuse eval still involves screening for a co-occurring mental disorder, because remember, that's dimension number 3 in your ASAM biopsychosocial assessment. You need to get a sense of, could there be something going on in the mental health arena that we may need to factor in when we make recommendations. Then the drug tests, you have to be aware of your chain of custody process in the office. We already talked about lab tests versus screening tests, or tabletop tests. Know your detection periods. That is key, because let's say you get a test and you test for ethyl alcohol and the client tests negative all the way through their treatment and you think they're doing great. The detection period for an ethyl alcohol test is a maximum of 12 hours. It only tells you if they're literally under the influence in that moment that they take the test. They could have drank 6 days a week throughout treatment and still test negative on that. So I encourage you to instead, or add, using ethyl glucuronide and ethyl sulfate, or ETG/ETS tests that extend the detection period up to 80 hours. So you need to know about stuff like that and know about confirmatory testing procedures. And I put a resource in the folder that you'll get access to that gives you information from the lab that I use anyway, that would be really helpful to know about drug testing. We already talked about this stuff. So when you write the report, we can't go into the report today. That's kind of a whole nother webinar, too much, but I can tell you, I recommend following the format that MBFE has officially recommended or provided to its evaluators. Don't stray from the focus of the referral source. Make sure that everything flows logically. So you make a diagnosis, then you do your clinical formulation and your conclusion, and your recommendation should all flow logically from one to the other. He has an alcohol use disorder, it's not in remission. His alcohol use is creating this pattern of problems for him. I've concluded he therefore needs some treatment to achieve remission, and so I'm recommending this level of care. It all should be flawlessly and seamlessly flowing through those sections. Make sure it's neat and well written with appropriate spelling, grammar, and formatting. Sometimes reports literally get tossed out for that. Avoid impressive psychobabble, because you're not writing for clinicians who are going to applaud your use of psychobabble. You're writing for judges and attorneys and sometimes juries who need to understand what you're trying to tell them. Keep in mind, when you recommend treatment, responsible drinking approaches sometimes work well for mild alcohol use disorders, but not so much for moderate to severe use disorders that benefit more from abstinence-based approaches. No treatment episode, outpatient or residential, ideally would be less than 90 days, even though for residential treatment, it almost never pans out that way. But for outpatient, you should never do less than 90 days of treatment. The greater number of exposures to treatment, the higher the probability of success this time around. And if you have leverage, as you do for forensic evals, use it. It's only when you don't have leverage, like clinical and therapeutic arenas where the client's self-referred, that you meet the client where they're at. And generally speaking, prescription of potentially addictive medication should be avoided for clients who have substance use disorders. And I have a reference from the APA's best practice guidelines for patients with substance use disorders that you can look into for more information on that. So when you write a recommendation, include this kind of information. What kind of level of treatment do they need? What should be the length and duration? What should be the focus of that treatment? What's their need for abstinence or sobriety and drug testing? Do they have co-occurring mental disorders that need to be addressed? Are there any concerns about current medication that could be making the problem worse that might need to be evaluated or looked into? And aftercare recommendations. If they go to the treatment and then the treatment professional recommends aftercare, write in your report they should just kind of go with any aftercare recommendations as well. Include treatment resources so they know where they can go to get help, and specify that every treating professional should review this report. Because if you don't, what I see is you could do the most thorough, wonderful evaluation, and you really do a good job of figuring out what this client needs. The judge orders them to treatment, but then they go to treatment and they deny having a problem with the treatment professional who says, well, I don't know what to do with this person, and just kind of BS's with them for 12 weeks. If that treatment professional had access to your report, then they could do their job and ensure continuity of care. That piece is missing a lot. So I write that into my report that whoever works with this client needs to review this report. So here's an example of what you might see in recommendations. It's numbered. I have that Mr. Ramirez should complete a minimum of 16 weeks of ACM level 1 outpatient substance abuse treatment focused on relapse prevention in a dual disorder enhanced program that can simultaneously address his co-occurring anxiety and depressive disorders. He should maintain abstinence from alcohol and illicit substances throughout his treatment, as evidenced by participating in random monthly urinalysis drug tests. You could add with the ETG ETS here to specify that alcohol is a problem and we need to have a better test. Number 3, he should comply with any aftercare recommendations offered by his treatment team. And finally, his treatment team should review this report. So how do you find treatment programs that might be appropriate? Well, one resource is SAMHSA's treatment facility locator for all of your licensed substance abuse treatment programs nationwide. And it gives you rich information about them, and you can look into those programs more. I got permission from Justin Fraser of Addiction Campuses to give you his information. This is a gentleman who we like to use here in our program when I do an evaluation, because his job is to stay updated on all of the residential programs nationwide, what their areas of expertise are and what they do and what they specialize in. And then what he does is if a client calls him or a family member calls him, then he asks questions to match them to the right residential program. What are they interested in? What do they like? What have they found helpful and not helpful historically? What's their payer source? Because that will certainly have an impact on the appropriate program. Are they high risk if they stay in this geographical location? Maybe we should get them far away from home for residential because they would be a flight risk, those kinds of things. And he's really good at alleviating concerns. I get wonderful feedback from clients about him, and he's available to be contacted if you need help matching a client to a program. He does awesome work. He's passionate about what he does, and it costs you and the client nothing. So why not? Now, to train more on this topic, this book, Essentials of Forensic Psychological Assessment, which I've referenced at a few points in the webinar, has a chapter on substance abuse evaluations that may be very helpful. It's just a good overview book anyway for any forensic evaluator. And then here's your ACM criteria that I mentioned earlier. If you're not already certified as a forensic mental health evaluator, I recommend that you train with us and get certified, because you'll learn so much about how to write a good quality report, how to testify in court, how to conduct evals, and we even have a 40-hour testing workshop that guarantees level C testing privileges with Psychological Assessment Resources, one of the major test manufacturers and distributors. So if you're weak on testing and you want to hit up on that more, that'd be great training to do. And then ASAM offers formal training on its assessment procedures. And then here's the SASE Institute if you want to learn how to use the SASE 4 or the other SASE related tools. And then seek certifications. Here are examples of credentials in the substance abuse arena. The more credentials that you have, the harder it is for opposing counsel to make the case that you are not an expert. So now we're at a good point to take in questions. And if we don't have questions, I'll show you guys how to use the DSM-5 cross-cutting symptom measure. So where are we at with questions, Norm?
Oh, we have a lot. The first one is from Vanessa West. She says, if we believe the client is being untruthful and misrepresenting information on the substance use disorder, how do we represent the truth accurately in a professional manner? Do we include AEB contradictions?
Yes. That's as evidenced by. So for example, those of you who are CFMHEs, you'll see in the sample report that MBFE gives you that I say in that report, you know, Mr. So-and-so reported this, but his report is contradicted by this. So you can just spell out the facts. That's all you gotta do is just spell out the facts. Here's what he said, but here's what I found. Here's what he said, but here's what I found. You absolutely would do exactly that.
Mike Holler. Many community mental health clinics are providing cheap evals done by non-licensed people.
Yes,
Comment.
Absolutely correct. Sadly, that is true, Michael. That's exactly the problem. And what's even more concerning about this is that many of them have contracts with the government to do that. So here at our drug court, there's a low, I guess I probably should be careful about what I say. I don't want to trash talk people, but there are agencies that literally have government contracts that provide very low quality evals. They always say the person needs treatment. I don't oftentimes agree with their recommendations and conclusions. Then the judge orders them to that same place to do said treatment, which tends to be, in my opinion, low quality treatment anyway. So that is a major issue in our field, sadly.
Tanya Douglas makes a comment. Aaron, I charge $200 per hour and usually take 10 hours, including testing and writing up the report. That's a comment. And she also asked, go ahead.
A good illustration of thousands that often these reports will be costing.
And she also asked, I know you mentioned resources at the beginning of the webinar. Will all the links you offered be in the email you are sending after the webinar?
Yes, you will get an email that will include that. And also remember that when you download the handout, all of the hyperlinks are active. So if you click on a hyperlink in the handout, it will take you to the resource that I linked it to.
Janice Wojak asked, could you discuss how a person addicted to prescribed medication who is not responsible for symptoms of medication per DSM-5 is, I guess, held accountable for a lack of a better term if person involved in a different negative behaviors? This is a little compound question. Does counselor have burden of proof through documentation? I wish I could be more in depth with this question out of practice with SA evaluations. Could you address this?
Yeah, I would recommend that you check out our webinar on what mental health professionals need to know about medical marijuana, because in that webinar, I go into great detail about what happens when you've concluded as an evaluator that a client's prescription medication is a problem in terms of their substance use treatment. I give interventions, I give template letters that you can send that spell things out. So it's a very lengthy, to give that question due justice, we would need a lot more time. But I would encourage you to check out that webinar. And if you don't know how to access it, you can do it by going to mbfe.net, click on trainings, then on-demand webinars, and find the medical marijuana training. Or you can email me and I'll give you some resources.
We have two more questions and a comment. Do you find that states have different hour amounts of treatment for IOP and EOP? I think most programs around here have IOP at less than 6 hours. How is that determined? Your slide didn't have IOP and EOP.
The slide did have IOP, but what it said is 9 hours minimum of programming per week. That is an ASAM number, but here in Florida, our DCF licensed substance abuse treatment programs use the same definition. But you're right, in other states, they may have slightly different definitions, different levels of care. So that will be something to factor in on a state-by-state basis.
Trista Moffitt asked, have you ever had a client decline signing of the release of information form? And I guess you would ask, what would you do about it?
Yes, clients have every right to refuse to sign a release form. But if they did that, I have to make a judgment call. Is this so critical that I can't complete the evaluation without it? If so, then I tell them that. I let them know that what this means is that they essentially won't be complying with the evaluation, and then whatever repercussions it has for their case, it has for their case. If, however, I determine, I really do feel comfortable finishing this evaluation without that one thing that the client wouldn't sign for, then what I would do is probably still do the eval and the report, but document their refusal to sign the release and factor that into my recommendations, because that tells me that, go back to the ASAM dimensions, readiness to change. If they won't let me get access to information, that may be a sign that they're less ready for change because they're still higher defense maybe.
And the last comment from Vanessa West, I guess this is a response to your previous response. Thank you very much, Aaron and Norm. This webinar has been very informative. Great job. Have a wonderful and blessed day.
Oh, well, thank you. That's a very nice compliment to see at the end of the webinar here. We appreciate that. Our goal here is really to help equip you with the tools that you need to provide quality evaluations, which, as you can see, I'm very passionate about. So I hope it's helpful. And understand we can only do so much in 2 hours. So I encourage you to keep learning. This is one of those fields where there's no ceiling on learning. So you can do that all the way throughout your career, and continue perfecting your craft as you do so. Any other questions or comments?
You're getting 2 more. Yes, very good from Pamela Paul. Great job, Aaron. Very thorough from Tanya Douglas. And thank you so much from Trista Moffat.
Wonderful. Well, then, in that case, the parting invitation I'll give you is if you have a question about today's training that you did not get to ask or that you come up with later, feel free to send me an email and I'll send you a follow-up response or try to point you in the right direction. And again, if you go to nbfe.net, click on training, and then you'll see 3 categories: live training events, including our live webinars, or on-demand webinars from the past, or home study programs. You'd click on the live training event, and then you can find that upcoming webinar. And keep your eyes peeled because we keep announcing new presentations. And finally, if you want to be a presenter, we would love to hear from you, because giving a presentation on your area of expertise, which may be very different than mine, is one great way to beef up your CV or your resume and further establish you as an expert in a particular forensic discipline. So please send me an email at aaron@nbfe.net if you're interested in being a presenter. And I think on that note, we'll close things out for today and wish you all a wonderful and fulfilling weekend.